In this lecture, I'm going to cover aorta pathologies and IVC anatomy and pathology. We're going to start with a list of the pathologies that are common to and that you should know for the aorta. There's arteriosclerosis, atherosclerosis, abdominal aortic aneurysms, aortic dissection, pseudopulsatile abdominal masses. You should know what an arteriovenous fistula is, a splanchnic aneurysm, renal artery stenosis, and then renal arteriovenous fistulas. We're going to touch on all of these briefly. Okay, first let's talk about the difference between arteriosclerosis and atherosclerosis. Arteriosclerosis is a disease of the arterial vessel that's marked by thickening, hardening, and loss of elasticity in the arterial walls. So what this means is the walls get stiff. Okay, so they're going to get stiff and it's going to make it hard for the blood to go through there. Atherosclerosis is a type of arteriosclerosis. You get the same thing. You get the thickening, the hardening, and the loss of elasticity in the arterial walls, but the arterial wall is also going to become irregular with plaque buildup. So if you think of arteriosclerosis as that stiffening of the walls, atherosclerosis is going to be the same thing, but with the presence of plaque. Okay, the plaque can build up and narrow the lumen. It can also obstruct the lumen if there's enough of it. And this can happen in any arterial vessel. If you have plaque, say, in your carotid arteries, you're probably going to have plaque in your aorta as well. Symptoms are going to depend on which arteries are affected, but again, common ones are going to be the heart. This is what causes heart blocks, the brain, kidneys, arms, and or the legs. All right, the ones we're specifically going to talk about today, we want to talk about aortic aneurysms. This is going to be any dilation, localized dilation of the abdominal aorta greater than 3 centimeters in diameter. So normal aortic diameter, if you'll recall, was anywhere from 2 to 2.7 centimeters. Anything above 3 centimeters is definitely an aneurysmal. That 2.7 to 3 centimeter area is sort of a gray area where it's at the upper limits of normal, may be aneurysmal, but may not be. Anything that's greater than 1.5 times the normal diameter is also aneurysmal. So if you got a little person whose aorta is maybe only 1.5 centimeters in diameter and you get a reading that's 2.7, that would be enough to be considered a problem, even though it was still in the upper limits of normal. You got two kinds, fusiform and saccular. Most of them are going to occur below the kidneys. They're going to be infrarenal. Surgery will be considered if the aneurysm is greater than 5 centimeters in diameter, because when it hits that 5 centimeter mark, we're going to see a greater risk for rupture and for dissection. And risk factors that will tend to predispose people to abdominal aortic aneurysms include tobacco use, hypertension, genetic conditions, cardiovascular disease, COPD, and family history. Tends to run in families. So this is what an abdominal aortic aneurysm is going to look like. And I just want to kind of quickly touch on what we've got here. So this is a fusiform aneurysm. And you can see it's a widening of the aorta. Okay. When we see it on ultrasound, what we're going to see is that we're going to get a major dilation of the aorta. This whole thing that I'm circling with the laser pointer is the aorta. Now, this darker anechoic area is the intact lumen of the aorta, and all around it what you're seeing is thrombus and clot from the aneurysm itself. And the same here, this is transverse, this side is sagittal. You've got that lumen here where blood is still maybe running through, but then you've got all this stagnant blood that's clotted off. And when we measure this, right, we want to measure from this spot right here all the way down to here. That's the total abdominal measurement, not just this lumen area. Okay? So we said we had two types. We have a fusiform and a saccular. Now the fusiform aneurysm is more gradual. It's more sort of a gentle curve in shape. And then your saccular aneurysm is going to be more round, and it's going to stick out more like a balloon from the aorta wall. Sometimes these saccular aneurysms can be mistaken for pseudoaneurysms, but the way I remember them is the fusiform aneurysm is a gradual widening of the length of that focal dilation, whereas the saccular is more like an outpouching. We got different places that these aneurysms can happen. The most common one is going to be infrarenal. Remember we said that's going to be below the renal arteries, typically right above the aortic bifurcation. You've got juxtarenal, which is adjacent to those renal arteries. Pararenal, which includes both sides of the renal artery origins, and then suprarenal, which happens above the renal arteries. So on our pictures here, these little ones that look sort of like arms on the dancing man with the top hat, those are your renal arteries. There's right renal artery here, left renal artery here. Okay, so infrarenal, juxtarenal, pararenal comes up on either side of those renal arteries, and then suprarenal is above those renal arteries. What are they going to look like on ultrasound? This one here is a very small dilation. You can see here's our normal aorta, and then as we get close to that aortic bifurcation, we see there's a slight widening of the aorta here. In transverse, it might look like this. You'll have that lumen we talked about. This is also a mild dilation. And here's the actual walls. I'm tracing those walls. See them there? You've got some thrombus in there as well. Here we got a larger aortic aneurysm, and again we'd measure all the way from this front spot right here all the way down to here. True aneurysm versus pseudoaneurysm. So when we talk about true aneurysm versus pseudoaneurysm, you need to understand what's involved. Okay, your true aneurysm is going to include both the it's going to dilation of all of the walls. Okay, so all three layers of the wall will be involved in a true aneurysm. In a pseudoaneurysm, it's not lined by all three layers. So what happens is you get a puncture of some sort. We see this with certain procedures where they go into the femoral artery through the groin. A place that we'll see pseudoaneurysms is in the femoral artery in the groin. Or with trauma. Something punctures the wall of the aorta, creates an opening that then does not heal, and outside of that wall, in the surrounding tissue, we get a hematoma that's closed off by the surrounding tissue. So you're going to get blood that's going to come down the aorta into this pseudoaneurysm, spin around, it's going to have to and fro blood flow, and then back down into the aorta. This is a true breaching of the wall. Here, we've got a widening of all three layers, but the walls are still intact. And that's the difference between a true aneurysm and a pseudoaneurysm. Okay, Again, pseudoaneurysms are hematomas. The blood leaks into the soft tissue next to the punctured artery, and you're going to get that fibrous encapsulation and failure of the vessel wall to heal. So the blood's going to escape through that hole and into that adjacent tissue. Think of it like a bruise, but on an artery, so it's got high pressure behind it, so it's hard for that artery to clot off and heal. Okay, now aneurysms, the biggest danger with them is that they can rupture. So if they rupture, the patient is going to bleed into their abdomen. The symptoms are going to be excruciating abdominal pain. Sometimes back pain is also involved. That may be their only symptom, is very, very bad back pain. But very quickly, because the aorta is the largest vessel in the body, you're going to see that they start to bleed out. So they're going to lose all of their blood into their abdominal cavity, and they're going to go into hypovolemic shock pretty quick. The mortality rate on this is about 50% if they're not treated quickly. Okay, and then the other thing you want to look for is the Gray-Turner sign. Okay, the Gray-Turner sign is a sign where you get discoloration in the flanks of the patient, and it's from all of that pooling blood. Okay, so their flanks are going to start to turn purple as they bleed out into their abdomen. Okay, now a dissection is different. Okay, with an aneurysm, what you get, right? We said with a rupture, you've got the aorta coming down like this. You've got that aneurysm, and you get a break. You get a rupture in the aneurysm, and then they bleed out, right? Just like that. Okay, with a dissection, you get, there's 3 layers in there, remember? And what happens is you get this tearing away of the inner layer of the aorta. So now as blood is flowing this way, it flows between the aorta inner layer and outer layer. So most of the blood is still flowing through here, through the lumen. But you get this tear, and as the blood moves into here, the tear gets bigger and bigger. Okay, that's a dissection. It's a splitting of the walls. And the dissections, there are going to be 3 types of those based on the DeBakey model. The first 2, types 1 and type 2, have a higher incidence of mortality. And CT is what we usually use to see dissections, but we can see them also on ultrasound as well. 1 and 2 are going to involve the ascending aorta and the aortic arch, which is why they have a higher incidence of mortality. They tend to happen higher up on the aorta. And then type 3 involves the descending aorta at the level inferior to the left subclavian artery. So the reason there's more mortality with those ones involving the ascending and the arch is because they can block off blood flow to the heart itself. So the heart becomes ischemic much faster. Okay, pseudopulsatile abdominal masses. These are things that can mimic aortic aneurysm, because one of the symptoms or signs of aortic aneurysm is a pulsatile mass in the abdomen. Other things can mimic that. One is a retroperitoneal tumor. Another is a large fibroid in the uterus. And then para-aortic nodes can also do that. Because they're adjacent to the aorta, the pulsations from the aorta get transmitted to the mass, and then it feels like the mass is pulsatile. Okay. Other things that are not quite as important, but you should be aware of: arteriovenous fistulas. Arteriovenous fistulas are going to be places where the artery and the vein come together and they connect without the benefit of the capillary bed. If you'll recall from our lecture on the cardiovascular cycle, we go from aorta to arteries to arterioles to the capillary bed, then venules, veins, IVC and SVC, and back to the heart. When we see an artery abnormally attached to a vein without the benefit of the capillary bed, you get an arteriovenous fistula. Okay. Splanchnic aneurysms are aneurysms of the SMA, the hepatic or the splenic veins. Okay. And then renal artery stenosis. Renal artery stenosis is arteriosclerosis of the renal arteries. So they get stenotic, they get narrow, and they get stiff. And then renal arteriovenous fistulas, same thing. They can be congenital, they can be acquired, but they're going to be an abnormal connection between the renal artery and the renal vein. Okay, so that covers the common pathologies for the aorta. I want to talk about the IVC a little bit and talk about the anatomy first, and then we're going to cover some of the pathology. Okay, so the IVC is going to be formed by the union of the common iliac veins. It's going to happen posterior to the right common iliac artery at about the same level, at the level of the fifth lumbar vertebrae. So you can see that split or that confluence as they come together when you're looking at the aortic bifurcation of the aorta into the iliac arteries. Right at that same level, you're going to see the two common iliac veins come together to form the IVC. Now, they also, don't want to forget about the median sacral vein as well, because that one is the third one that dumps in right there to help form that IVC. It's going to ascend vertically through the retroperitoneal space on the right side of the aorta, posterior to the liver. It's going to go through the tendon of the diaphragm and enter the right atrium of the heart. It's going to serve as a landmark for many other abdominal structures, and we should look at it on all exams. Okay, so the intrahepatic portion of the IVC, we can see it by using the liver as an acoustic window. Inferior to that, you're going to have a hard time sometimes seeing the IVC because of overlying bowel gas. You can see it fairly well again at the distal portion where it's formed by the confluence of those iliac veins. And we do image it in both transverse, which is not on here, and in sagittal. Okay, so here's that quick anatomy of the IVC. You've got the right common iliac vein, the median sacral vein. Let me turn on my laser pointer. Right common iliac vein, median sacral vein, left common iliac vein. They're going to come together. They're going to form that IVC. You've got several lateral tributaries. Remember, they're not branches because they're not branching off. They're tributaries because they're dumping in. Okay, so several lateral tributaries known as lumbar veins. You've got the right gonadal vein is going to dump directly into the IVC. One thing to keep in mind is the left gonadal vein does not dump into the IVC. It travels up and dumps into the left renal vein. And then the two renal veins, both the left and the right renal vein, dump into the IVC. So only your right gonadal vein actually connects directly to the IVC. The left one's going to typically go through the left renal vein. And then you've got the two renal veins as we talked about. The left suprarenal vein also dumps into the left renal. On the right side, the right suprarenal vein is going to be its own tributary into the IVC. And then up here we've got the hepatic veins. There are three of those, remember, a right, a middle, and a left. They're going to sort of mimic the celiac axis. but on the right side and involving the IVC. And then it's going to pierce that diaphragm and head for the chest. Okay. Here's those hepatic veins again. You can see the left one, the middle one, and the right one all coming together and dumping into the IVC. All right, so pathologies, things you should know about, congenital abnormalities. The IVC forms in sections during embryology, so sometimes we will see that there's a double IVC or there will be an interruption of the IVC, and it will develop with an actual part of the IVC not there, but it'll always find a collateral pathway to the heart. Okay, so if we have duplication, if we have a double IVC, what happens is you'll have a left one and a right one. The left one's going to join the left renal vein, and then it'll cross the midline to join the right IVC. Okay. If you've got interruption, it's going to use the azygous or the hemiazygous veins. They're going to be still intact, and it will use those to form those collateral pathways that we talked about. Just like you can have dilation of the aorta, you can also have dilation of the IVC. The most common problem you're going to see is IVC tumor, and the tumor can be from different things, but oftentimes we're going to see it coming from renal carcinoma. That's the most common reason to have tumor in the IVC, is it's growing from the kidneys in the presence of renal carcinoma. Okay, and then the last thing is IVC thrombosis. This is the most common reason for pulmonary emboli, is going to be thrombosis in the IVC. Typically we see it originate in the lower extremities and then work its way into the IVC and up to the heart, where it then travels to the lungs. So that's a quick rundown of the aorta pathologies that you should be aware of, anatomy for the IVC and pathology for the IVC.